So anatomical orientation is an essential basis for the US examination, and if you are fit in anatomy, normal anatomy, you will understand as well pathologies. So the beginning was the demonstration of the wall layer structure. You see here the typical image of a wall layer in the stomach with a normal transducer and with a high frequency mini probe. And normally we have a 5-layer structure beginning with the entrance reflex, then the muscularis mucosae, and then the submucosa and the proper muscle layer. And this is similar whether you use a radial probe or a longitudinal probe. So this is the image of a longitudinal probe. You have only another section plane, but there's no difference in the layer structure. If you use high-frequency probes, you have more layer structures. This is the reason is that you are able to see the outer longitudinal muscle part of the proper muscle layer and the inner ring part of the proper muscle layer. And this is nearly histology, and up till now we have no other technique which is able to demonstrate this layer structure. There's still a matter of debate. How is the orientation in longitudinal US? Is cranial on the left side or is cranial on the right side? So we use the orientation like in abdominal ultrasound. So if you make a longitudinal section through abdominal ultrasound, you have on the left side cranial, and we use it in the US image as well. So in the following part you will see the direction left is cranial in longitudinal US. In radial US, I recommend always to rotate the instrument so that the spine and the aorta is located at the 6 o'clock position. This is much more easier for the orientation. So you have a similar orientation in transverse sections like CT scan. In radial scan, you have more push and pull maneuvers to find your reference positions. In longitudinal scan, you have more rotation maneuvers, and this is an anatomical simulation in our training tool for longitudinal US. If you rotate, if the transducer is directed dorsally and you rotate the instrument to right, it goes to the left side of the body. And if you rotate it to the left side, it goes to the right side of the body, as you can see here. You can follow the portal vein. So the most important thing is that you have special reference positions in the mediastinum, in the stomach, and in the duodenum. And they correlate sometimes with the depth of introduction of your instrument. So you have the upper part of the esophagus, middle part or lower part of the esophagus. You have a very important point at the level of the cardia and the fundus. Then you have the duodenal bulb and you have the level of the papilla. At each of these reference positions you find your guiding structures. For example, in position 1, in the upper esophagus, the descending aorta, the aortic arch, the archegos vein, and the aortopulmonary window. In the position 2, as well in the mediastinum, in the middle esophagus, the heart, the pulmonary artery, and the trachea, and the bronchi, which is very important, for example, for the staging of pulmonary cancer. Then you come downwards into the stomach and the duodenum with the position 3, in the cardia or fundus with the abdominal aorta, the celiac trunk, the superior mesenteric artery, and a very important point is the splenic artery and the splenic vein, together with the pancreatic body and tail, the splenoportal confluence and the left liver lobe if the instrument is directed ventrally. In position 4, you have the duodenal bulb only with the portal hilum, for example, the gallbladder and the proximal and middle common bile duct. In position 5, this is the papilla with the mesenteric vessels, the pancreatic head, pancreatic duct, and the distal common bile duct together with the portal vein. So we go through these positions. We start with position 1 at the level of the aortic arch, and that's very typical for radial scanning that you have ventrally located the aortic arch, so you make a transverse section through the body, through the mediastinum you see here, together with the left lung, the reverberations of the left lung, you see the aortic arch. If you go a little bit deeper, you see the crossing of the pulmonary trunk under beneath the aortic arch. On one side you see the ascending aorta, on the other side the descending aorta together with the spine, and this is the pulmonary trunk, a very, very typical image for radial scanning. So if the transducer is directed dorsally, you can follow the aorta, and you see the hemiarchegos behind the aorta, and on the other side you see the archegos vein. And sometimes you see the stairs or the steps in between, the connections between the hemiarchegos and as well the archegos, crossing behind the esophagus. So in longitudinal scan you have a completely other section there. So you have a cross section through the aortic arch. It's very normal that you see better in longitudinal EOS the exciting vessels which are coming out of the aorta. And this is as well from the Voxelman training tool. You see here the aortic arch, and you see in this case the left subclavian artery is coming out of the aortic arch and the corresponding EOS image. This is very typical, and if you come deeper, like in the radial scanning, you can see as well the pulmonary trunk in a longitudinal section behind the aortic valve as well, a very typical image together with the right ventricle and the right atrium. In longitudinal scan, you can as well follow the archegos vein, but you should not compress too much against the esophagus wall. You see the inflow at the level of the superior cava vein. This is the archegos vein. And now you can follow downwards along the archegos vein on the right side of the spine, not on the left side. On the left side is the aorta. Very important point is as well the trachea and the bronchi. You know that air is the enemy of ultrasound, but you can see the trachea with a very typical image with the reverberation artifacts of the trachea. And you move, if you move down the radial scanner a little bit, you see the bifurcation. On the right side you see the right bronchus, on the left side you see the left bronchus with a very typical reflex. For the bronchus it's as well very typical that you have no reverberations artifacts, you have only air-filled lumen, and you have a very small echo-pure wall. So this is a differentiation to the trachea. Now we are coming to position 2. It's a very easy position because you see the beating heart, and you have only to know and to realize that the left heart is close to the transducer and the right heart is far away from the transducer, and sometimes it's difficult to see the heart in the complete demonstration of the right heart, for example. But in this case it works. This is the left atrium, the aortic valve, the right ventricle and the right atrium, a very cross section through the heart with the radial scanner. If you see it in the video, we are coming from the inferior cava vein. This is the descending aorta. Now we pull back the instrument, and you see already here the beating heart is coming, the left atrium in front. You see the spine is located at 6 o'clock, so it's easier for you for the orientation. You see the left atrium together with the pulmonary veins, and you follow only up to the level of the pulmonary trunk. Now comes the trachea here with the reverberation artifacts and the aortic arch. In longitudinal scan, it's sometimes easier to see the left ventricle with the strong muscle. You see the strong muscle here, and you see the left ventricle corresponding to the level of the mitral valve. And as well in the video, you see the mitral valve and the strong muscle and the left ventricle downwards in front, always close to the transducer, the left atrium. The next step is to see the pulmonary trunk together with the aortic arch, and then you follow down with the scanner following this descending aorta. So you go this way along, the esophagus is behind, and you go backwards, it's in front, and you go backwards, downwards into the stomach. So you see first with the longitudinal scanner the exciting vessels. In this case, the subclavian artery, then comes the carotid artery, and then you have a cross-section through the aortic arch, and you will follow downwards. You have always behind the aorta, you have the typical reverberation artifacts of the left lung, and you have only to move downwards the scanner along this descending aorta. The difficult part is the level of the cardia, because you have a lot of vessels at this point and a lot of tubular structures, like the cellular trunk, supramesenteric artery, and the splenic artery and supramesenteric artery. Therefore, it's more difficult for you for the orientation. You see that the celiac trunk has two important vessels. On the left side is the splenic artery, on the right side is the common hepatic artery, but you have as well the left gastric artery, and sometimes you see as well the gastroduodenal artery if you go downwards from the level of the common hepatic artery. The next problem is if you are at the level of the liver hilum, you have a lot of vessels there, like the portal vein, you have the supramesenteric vein, you have the splenic vein, and together with the common bile duct, but it's a very important guiding structure for you to find the common bile duct. So this is a video of the typical image of the celiac trunk, bird-like celiac trunk. On the left side is the splenic artery, on the right side is the common hepatic artery. This is a very typical image for radial scanning. And you see sometimes if you retract the cross-section through the left gastric artery here. But it's similar to abdominal ultrasound, to transverse section abdominal ultrasound, therefore it's easier. Then you can follow the splenic vein, and you have always in front, close to the transducer, the pancreatic body and the pancreatic tail. Here you have the aorta, the inferior cava vein, and now comes the splenoportal confluence, the supramesenteric artery, together with the uncinate process of the pancreas. As well, a very typical image, transverse section, like in abdominal ultrasound of the pancreas. Sometimes you are as well able to see the pancreatic duct, especially if you have a 90-degree location of the transducer, so the ultrasound waves go directly to the pancreatic duct. Then the depiction of the pancreatic duct is easier, especially in the body. It's more difficult in the tail sometimes, and in the head is as well easy. But the most important guiding structure for you is the confluence together with the splenic vein and the splenoportal confluence. On the way to the pancreatic tail, you see the very typical image of the left adrenal gland. You can see the left adrenal gland is a seagull sign, or a very typical sign, together with the diaphragma. This is the diaphragma behind, and the upper pole of the left kidney. So it's easy to follow only along the splenic vein. In longitudinal scan, you have another plane section. You have a longitudinal section through the aorta together with the celiac trunk and together with the superior mesenteric artery. And this is this image again in the Voxelman. You see the spleen, the celiac trunk together with the left gastric artery. And here's the superior mesenteric artery. This is the aorta. And this is the corresponding image, left gastric artery here, and here's the celiac trunk. And if you rotate to the right side, you will follow the splenic artery. If you rotate to the left side, you will follow the common hepatic artery. So this is a video. You see the celiac trunk, and together with the superior mesenteric artery here, this is the aorta, and here's the very small left gastric artery going cranially to the stomach wall. Behind the spine, behind the aorta. So this is the superior mesenteric artery. This is the left gastric kidney vein. So as well in longitudinal scan, you see has the possibility to see the left adrenal gland, a very typical image. This is the anatomical image of the left adrenal gland. A very important vessel is the splenic artery and vein, because if you go downwards along the aorta, you will very often see two eyes. The upper one, cranial located, is very often the splenic artery, and the lower one is the splenic vein. And this helps you to find the pancreas, the pancreatic body, especially in longitudinal scan. Another typical image is the inflow of the superior mesenteric vein in the splenoportal conference together with the splenic vein. This is easier with the longitudinal scan, but it's a very important section to find the common bile duct if you are in the level of the fundus and of the cardia. The position 4 in the duodenal bulb is very easy because you have normally the liver hilum and the gallbladder. You see the gallbladder with the infundibulum here in the radial scanning. I think in the radial scanning it's sometimes easier to see the full gallbladder. It's more difficult with longitudinal scan because you have always to rotate the instrument, and especially the fundus is more difficult to find with the longitudinal scanner. So this is a longitudinal view. You see, you have to rotate the instrument, but you have difficulties here at the level of the fundus. But you can do easily abdominal ultrasound to examine the gallbladder. Another typical image are the Heister valves within the cystic duct. You see here the anatomical image of the so-called Heister valves. It's very easy, but you can mean that this may be a polyp, but this is a normal anatomical structure. At the level 5, we are at the level of the papilla, together with the major and minor papilla, the pancreatic head, the common bile duct, the cystic duct, and sometimes the gastroduodenal artery, together with the superior mesenteric artery and vein. These both vessels are your guiding structures to find the common bile duct. So in radial scanning, you see first the deep parts of the pancreas, and then the very typical image of the ecopure ventral part of the pancreatic head, together with the pancreatic duct, and in front, close to the transducer, the common bile duct. This is very typical, and if you look for example, pancreas divisum, you will never see the pancreatic duct going in the dorsal part. So this is a complete common bile duct in radial scanning. I think it's easier to see the common bile duct for the beginner with the radial instrument, because you see the whole length of the common bile duct together with the cystic duct. This is a longitudinal scanner, but as well at the level of the papilla, you see the common bile duct here in front, and you have to rotate to the right side to see the pancreatic duct within, again, the ventral part of the pancreas. So last not least, you know that tomorrow you will have a lecture about training in US. It's the last lecture, I think, and Peter allowed me to show you very short our new training system. It's a training system for invasive, especially USFNA training and interventional US. We did it in cooperation together with the Ultrasound Science Center in Halle. It's a permanently waterproof case, a closed system. This is the advantage is that you have no artifacts within this case. And within the case you find you have two accesses for the stomach, and you have one access for the rectum, and there are PICC organs embedded in an ultrasound capable matrix. You have a lower matrix and upper matrix, and then you can close the case, and then you fill water inside, and you have no artifacts during the training. You see now the matrix is here. You see the rectum, you see the esophagus and the stomach, and they are surrounded by structures, by lesions where you can train the puncture. You can make a training of solid lesions, and you can control the material. If you have red material, you are in the lesion inside, and if you have white material, it was wrong. And you have the possibility to make drainages of bladders close to the esophagus. And if you close the case, the box, you have as well tubes to refill the bladders. So you can put a plastic stent inside, you take it out, and then you can refill it. You can do it, I think, 10 times. So this is a short video of the trainer. So this is the access to the stomach, and you have a normal view within the lumen. You will see it. This is the layer structure. You can see very good the layer structure, the normal layer structure, and you see the lumen. You can give air and can demonstrate. This is a demonstration of a solid puncture of a solid part, the red one, a colored one, within, so you can easily monitor the needle within the lesion, and it looks like a liver lesion, for example, hemangioma. And it's very easy. This is an Axios stent, is placed in a bladder, so it's filled with water. You can as well fill some other substances inside. You see the stent, the deployment of the stent. And you have an electrosurgical connector to make any invasive or interventional training. So the Axios stent is placed now. So you have the possibility to make X-ray control. You can make balloon dilation within it. And you have a control by fluoroscopy. Where you are, you can see the stent, the deployment of the stent. And afterwards you have a control. If you open the case, you see how was the intervention. So this is the rectum with the prostate. We use it as well for urological training, for puncture of the prostate, for example. You see the refilling of the bladder. It's refilled from outside. And we have as well the possibility to make fusion technology with this system to train. Sometimes you know that sometimes you see lesions only in MRI scanning, not in ultrasound scanning. So you have to train fusion technology. On the one side you have the CT scan, in this case, on the other side the ultrasound image. And last but not least, in October we started as well to train perhaps hepatic gastrostomy, and we did an artificial bile duct system within the system, and it seems as well possible to make training to make a drainage of the bile duct system, artificial bile duct system. You see very easy the guide wire is going within in the tubular structure. So this is a short demonstration of the trainer. The conclusion is anatomical knowledge is an essential basis for EOS, and I think you should search always your reference position and always orientate on guiding structures. And I think it's as well very important to straighten your endoscope and make small movements to find the guiding structures. In radial scanning it's more push and pull. In longitudinal scanning it's more rotation. And the trainer is a good tool, I think, new tool for realistic training of invasive and interventional EOS. Thank you very much.